Record on this computer. Okay, we're recording.
Sure.
Okay, everybody, welcome to the CGHS Research webinar series hosted by the Public Health Programs. And today we're going to be hearing from Paul Frizelle. He's one of our alumni and also one of our adjunct instructors in the kinesiology program. Dr. Paul Frizelle received his Bachelor's of Science in Sports Management from the University of Tampa in Tampa, Florida. After completing his bachelor's, he attended A.T. Still University and received his master's degree in human movement. And then he received his doctorate of physical therapy from the University of St. Augustine. After graduating from USA, Dr. Frizelle moved to Washington, D.C. metro area and completed his residency in orthopedic manual physical therapy. His current certifications include Orthopedic Clinical Specialist through the American Board of Physical Therapy Specialties, that's the ABPTS, Manual Physical Therapy through the University of St. Augustine, Certified Strength and Conditioning Specialist through the National Strength and Conditioning Association, and certifications from the National Academy of Sports Medicine in Performance Enhancement and Corrective Exercise. He currently works as an outpatient physical therapist specializing in orthopedic injuries with a special focus on working with young athletes. He has also given talks around the country on rehabilitation topics, ranging from injuries in the young athlete, rehabilitation of the hip and pelvis, rehabilitation for joint replacement, and evaluation and treatment of the lower extremity. So with that, it's all yours, Paul.
All right, Marcia, thank you very much. So our talk today is going to be on the epidemiology and prevention of injury in the young athlete. It's a topic area that I enjoy as far as working with, and a lot of really, I think, meaningful research coming out in this topic area. So we're going to see if we can cover some bases with that. We're also going to look at some of the more common injuries that you may encounter if you work with these athletes, either in a rehab or in a physical education setting, athletic training, or even strength and conditioning. And we'll discuss some of the potential ways that we can work on both injury prevention and then helping these individuals to stay involved in athletics and become active adults. So you guys all heard about me, so this is just in case you just logged on. So my background, again, primarily a physical therapist and a little bit of work in orthopedics. My current work background full-time is as an outpatient physical therapist. I've also worked in acute rehab hospitals, and I've been fortunate enough to be involved with AT Still ever since graduating with my master's degree in 2009. So, and I live in sunny Florida, so it makes me happy to stay in a warm area. I've had enough of the cold, So I wanted to just kind of cover our objectives for the time that we have together, because we're actually going to cover quite a bit of ground in what's really a pretty short period of time. So I wanted to let you know what we're going to be looking at. So to start off, we're going to look at some of the factors associated with today's young athlete. Some of these factors include practice time, age, sports specialization, and some of the biopsychosocial aspects that you may encounter if you're working with these individuals. We're going to talk about the most frequent injuries based on the research that's seen in athletes between 5 and 17 years of age. We're going to talk about some of the unique anatomical considerations in the young athlete. Right? The anatomy of the developing individual is significantly different than working with somebody who's already a mature adult. So it's very important to know this background and to understand it as you're working with these people. We're going to discuss the more common injuries that you're going to see in these individuals, which include apophyseal injuries, ACL tears, spondylolysis, and concussions. And then we're going to look at some potential ideas for strategies for both injury prevention techniques, and then how do you manage these patients and these individuals if you're working with them after they've already been injured. To start, meeting the young athlete, there are some characteristics which are definitely unique that you're seeing as you're working with these individuals. One of the big characteristics that's really seen a lot in the research and noted to be associated with injuries is that single sport specialization, which means uh, athlete that's considered to be a single sport specialized athlete is somebody who plays one sport only for a majority of the year. Usually, most of your sports specialized athletes play it all year round. But this is definitely something that's changed and evolved. You used to see people participate in multiple sports, not as much anymore. Often you're going to see these individuals in the specialized sports are going to practice more hours per week than their age, which in some research has been shown to correlate with a higher risk of injury. Also, some of these athletes, you may see individuals who may not necessarily always be like that. You have to be able to identify the differences between the two, because some athletes that you may intersect with, they may have lower level performance expectations. They may just enjoy playing a certain sport. They may not have collegiate level aspirations or higher level performance aspirations. So it is important to recognize that those athletes are out there. And then overall, when you're identifying and working with these young athletes, it's important to identify all the stakeholders that are involved in working with these athletes. And we'll talk about stakeholders here in just a minute. Some of the trends that you're seeing in sport participation, again, the idea of the sport specialized athlete, which means that they play a single sport for a majority of the year. A lot of what you're seeing in the trends in sports participation is that these single sport athletes are starting their sport at a much, much earlier age, sometimes 5 and 6 years old, especially with sports like gymnastics, tennis, wrestling. So you see a lot more skilled practice time at much younger ages than we've ever seen in this population prior to this. Also, the stakeholders that are involved with these athletes are definitely different. It used to be primarily just the school, right? Whatever school that student or athlete attended was the primary stakeholder. Now you see stakeholders include the athlete, the parents, the coach, the team, which may be the team in school, and you may be talking about multiple teams outside of school, including travel teams, alternate leagues. AAU is a good example of this. So you've really got a lot of different groups of people, all with ties into this athlete, which is definitely a unique thing. Also, one of the trends that you start to see when you have these young athletes that are participating in a single sport from an earlier age, I see a lot higher loads going into younger developing athletes. And generally, somebody with less experience and less skill has poor biomechanics, right? And so the combination of these higher loads, younger participation, and poor biomechanics is all kind of factored in to what we're seeing in our injury trends in these athletes. The big picture is we're really starting to see a collision of two extremes when we look at young athletes and young kids involved in participating in sports. On one side of it, we have a rise in childhood obesity rates, right? This has been well documented. We see it over and over again. Kids are more and more overweight than they've ever been. And athletics has always been promoted as a primary tool to help kids get more active and become healthier overall physically. You've also seen a decrease in what's termed unorganized play, which is the type of play that is seen when the kids go out to the playground for the recess, they pick up a ball, and they make up the game. There's no rules. It's an informal game. Those types of unorganized play activities have been shown to develop motor skills and motor coordination in much different patterns than you see in organized play. So this change in how kids participate in recreation and sports has really caused a change in the development of the athlete. And I think that that's part of what's contributed to this rising injury trend in your young athletes. Also and I'm a parent, and I have a bunch of young athletes in my house, and I can vouch for this. You got a rise in costs to participate in all of these different types of organized athletics and organized activities. You've got specific teams, kids are trying out for teams, and you're paying money to travel with them. So really people start looking at these sports as more of an investment than they ever have before, right? So it really has started to change around how we visualize what sports and athletics does for the young individual. Rather than just being a physical development tool, it's really started to look at it as, okay, we're going to get them into this so they could get into college. And if I invest this much, then we'll get to here. So it's really taken on a whole life of its own. As we start to look at just some of the research that's out there on injury trends and injury patterns in your pediatric and adolescent athletes, was a nice study from 2013 that took a nice sample size from a hospital in the Northeast that specialized in working with young athletes. So the sample size in that study was 2,133, and they looked at athletes from the time period of 2000 to 2009. To see what they could identify for injury trends or common injury patterns in that time period. So what they did see is that approximately 50% of that sample size was being treated at that hospital for some type of overuse injury, which means that that athlete sustained that injury from repetitive motion, right? Doing that same pattern over and over again. Your lower extremity injury was the most likely injury to be seen in all age groups. And as they broke it down further in the research to age categories, what they noticed is that your younger athletes, ages 5 through 12 years old, it was about a 50-50 split, right? 50% of them had overuse injuries, and then 50% of them had those acute injuries. An example of an acute injury that you might see in an athlete is the athlete that twists his ankle after landing on an opponent's foot, right? That's different than an overuse injury. Your older athletes, 13 to 17 years old, these had a much higher percentage of athletes that were more likely to be overuse injuries. And, if we kind of think why that might be possible, your older athletes have just been playing longer. As they get older, the competition level gets higher, and you see that trend towards only playing a single sport, especially once they hit about the 13 to 14 year mark. So definitely some patterns in these different age groups were very identifiable. As we looked at the most frequent injury across all age groups, 5 all the way through 17, you're looking at fracture being the most common injury across all those age groups. In the 13 to 17-year-old category, your second most frequent injury was an ACL tear. In the 5 to 12-year-old, your second most frequent injury was an apophysitis. And this is something definitely, if you're working with young athletes, apophysitis is a term that you want to be aware of. It's going to give us one of the more significant differences when we start looking at a young athlete compared to a mature athlete. So we're going to go over all of these here in a little bit. But some high frequency injuries that were identified across both of the groups included osteochondritis dissecans, Patella femoral pain syndrome, and I capitalized it primarily because I thought it was really interesting, but pain, right? Just pain was one of the highest frequency problems that was seen across all of those age groups. And in the big picture, you generally know something's wrong when somebody who's between 5 and 17 years old is complaining of pain. Usually you don't hurt when you're that young. You hurt when you're older like me, right? But not when you're that age. So pain is a big, big problem in those age groups. Concussions may represent your most underreported injury in those age groups. A.T. Still University and Dr. McLeod, and we're going to look at some of her discussions and interviews later, but there's a lot of really, really great research that's being generated out of our university on concussions. So, but it's really only picked up traction being reported in both the medical setting and in the literature, I would say in probably the past 5 years. So we may not see as much concussions reported as actually is being seen on the field in current clinical practice. For big picture implications of poor patient management, You're really looking at long-term injury, right? Early onset of musculoskeletal problems, which include osteoarthritis, unstable knees, chronic pain, depression, right? If you've got somebody who's used to participating in some type of group and social activity and they're removed from that activity, it's going to affect their overall outlook on life. So depression is a big component of not helping these individuals be able to return to the things that they like to do. Overall, in the big population health standpoint, decreased participation in exercise and physical activity in young ages is going to lead to chronic disease in later ages. So managing these individuals early, really, really important to our long-term population health. And then, even this is probably not the biggest percentage of the people that we'll encounter, but some people will continue on to participate in higher level athletics, collegiate level, maybe even professional. And if they get injured early, they're not going to be able to try to move to those levels. So you really have got a lot of implications of not doing a good job at identifying and managing these patients well. All right. Moving into some of the anatomical considerations for the developing athlete. I had some just points that I wanted to touch on, and this is going to be a very, very brief overview of these. We could spend almost a week on each one of these topics individually, but we're going to look at endocrine systems, skeletal changes, muscular changes, and some different risk factors for injury, and then some of the rehab approaches, both physical and mental aspects. So in the endocrine system, especially with female athletes, there's some very good literature coming out about the effect of athletics and the changes that female athletes go through and how these two things can combine to onset for problems. So your hormonal changes in the pubertal stages are going to have a significant effect on both physical and emotional characteristics of both male and female athletes. Female athletes are generally going to have an earlier onset of these changes of puberty. One of the big things that we as people who work with these athletes need to be aware of is the potential of what's termed the female athlete triad. The female athlete triad, really what it includes is a reduced energy availability, altered menstrual function, and decreased bone mineral density in a young individual. It's important to recognize this risk in the early phases because, again, if we treat this early, we have a better opportunity to have this individual have improved health later. And especially if we look at bone mineral density, most of the research shows that most of your bone mineral density is built when in the early years of life, right, up until about age 20. So this is a very, very important group of people to work with and be able to identify this problem early to set them up for success when they're younger, but also improved health later on in life. And some of your risk factors for the female athlete triad include your early age specialization athlete, athletes in weight class sports, also athletes that have been identified in sports where there's a high focus on visual aesthetic. Gymnastics is one of these types of events. Volleyball, believe it or not, because of some clothing that's worn. Also, endurance sports athletes, cross-country runners have also been identified as part of this risk group. Important to recognize, we may be some of the first people that talk with these individuals about things that they should be experiencing that they're not. One of the things may be altered menstrual function in these early phases of puberty. Also, what they see in the bigger picture is that decreased potential bone mass in the young female is due to the higher propensity of this altered menstrual function. So this is something, again, both in the early stages, but in the long term, it's a very, very important thing for us to be aware of. Even if it's not within your scope of practice to be addressing this, discussion with the athlete's parents or referring that athlete to the appropriate healthcare professional to begin looking at this can be a very, very important early step. So anybody who's working with these athletes, even if it's not within your scope of practice, you still need to be aware of this and be aware who could help this individual the most. The biggest picture thing that they found based on the research is that the female athlete triad, one of the biggest things to manage it effectively is improved nutrition. So a lot of times the calorie intake versus the calorie output is significantly mismatched already in a young athlete. And then when you couple this with people that are in weight or visually conscious sports, they may reduce their nutritional intake even further. So working with a dietitian may be something that may be a necessary component of managing these people. But they found that by managing the nutritional intake better, it actually allows the athlete to have more normalized function rather than always going to the idea of telling the athlete to stop training. Because a lot of times you'll find athletes don't go to a healthcare professional because that's what they hear so much. Right? I don't want to go to the doctor with this because they're going to tell me I can't play anymore. And I've seen a lot of that in the rehab setting where athletes will say, no, I'm not going to physical therapy. They're going to tell me I can't play. So really helping the athlete to understand, here's what we want to do. These are things in the big picture. I want to help you to be able to do this, but this is what you need to be able to do. So definitely this is information I think really, really important to be able to get across to the athlete or to the stakeholders of that athlete. Other components of the endocrine system in the young athlete, the big picture, and again, this is male or female, your below optimal nutritional intakes in these individuals is going to result in a higher likelihood of injury. Again, what's been found pretty consistently is your athlete that are in weight-dependent sport or visually aesthetic-based sports are more often affected by these nutritional imbalances. Some of these sports, and a lot of times these sports don't get as much publicity because they're not part of baseball, football, or basketball, but wrestling, gymnastics, figure skating, volleyball, tennis, these are all sports that have a high basis of visual aesthetic and a high visual appearance, and weight monitoring a lot of times is a constant part of what these athletes do. So it's something for us to be aware of when you're working with an athlete that's not part of the big three sports, right? There's a lot of things going on that we need to know and be able to communicate with the different stakeholders. And again, even if it's not within your scope of practice, communicating with the athlete, the parents, the doctors, the coaches, really helps to improve the overall outlook for the long-term management of potential injury of that athlete and then the long-term health of that individual. Looking into the anatomy of the adolescent skeleton, the defining factor of the adolescent skeleton is going to be your growth plate, right? The open physis. This is what allows the bone to continue to lengthen. And when we get to adulthood, when the body stops growing, that physis shuts off. So that physis is an area of inherent weakness in the bone. It's an area that has a high risk for injury in the young athlete. So one of our big picture things, and I've kind of hit on this topic a lot, there's a lot of evidence that's come out showing the correlation between muscle strength and health of the pediatric and adolescent athlete. So the athlete that's younger and that's stronger and participates in regular resistance training exercise has a decreased risk of injury, but also has been shown to have better overall health and bone mass later in life. Well, so really important, the awareness that, because this is kind of one of those big myths that's been out there for as long as I've been involved professionally in exercise, is that resistance training is not good for somebody that's under 14 years old, not good for somebody that's under 16 years old. It's going to stunt their growth, right? Nothing could be further from the truth. And there's just mounds and mounds of evidence coming out to help us identify that that's not true. So again, when we look at the adolescent athlete, one of the highest times of risks for these individuals is periods of rapid growth, right? That's when the bone itself is inherently even weaker than it normally is due to that rapid growth period. Your fascial injury is actually kind of an underdiagnosed injury. Most of the time, it's diagnosed as a muscle strain. Generally, people that have stopped growing, more likely to get a muscle strain. People that are still in their growth phases, more likely to have some type of fascial injury. So again, really important to know the differences between these two and understand where that athlete is in their growth cycles to know whether or not this injury is what they could be affected by. Some of the classifications of fascial injuries, this might be a little outside of what's needed, but if you're working with a doctor or the patient or the athlete tells you this, this is the type of injury they had, you might be a little more aware of what they are. So a grade 1 or grade 2 on the Salter-Harris scale, minimally displaced fracture, right? With treatment's really going to be directed towards managing the symptoms, which is pain, muscle weakness. Wider displacement is seen in grades 3, 4, and 5. A grade 3 or a grade 4 Salter-Harris fracture of the fascial junction is going to require, I shouldn't say it's going to require, may require surgery, depending on the nature of the injury, how it happened, and the significance of the displacement of the bone. Your stage 5 Salter-Harris injury is going to result in growth arrest of the bone. Right? So that bone will cease growing past that point. It'll seal down. So if the rest of the body continues to grow and that bone doesn't, what you're going to get is you're going to get an imbalance as that person ages. And you're going to see some pretty significant long-term changes because of that type of injury. When we look at muscular development in the young athlete, Feigenbaum, he really is probably one of the leaders in the research in this area, and he's really come out with a lot of great information about the importance of progressive resistance exercise in not just the young athlete, but in young people, adolescents across the board. So one of the big myths is that a young person doesn't have the capability of building muscular strength, right? Because they haven't gone through puberty yet. That's been shown to be totally false. Young athletes have the capability to build muscular strength, very similar to those who are older. What's been shown is that appropriate progressive resistance exercise reduces the injury risk for sport. It also shows that there's a greater likelihood for higher level performance with the application of appropriate resistance exercise program in conjunction with sport performance. One thing that you do find, and this is something everybody always says, and I hear it a lot in rehab, my son, he needs to stretch. He's got to stretch. He's so tight. He's so tight. All young athletes are generally tight, partially because they're growing so fast that the musculotendinous unit can't keep up with it. So your young athletes, they're going to be tight. It's not something that by stretching constantly every day, all the time, they're suddenly going to not be tight. It's part of what you're going to see because of the development of that young individual. So it's not something that's necessarily terrible. A lot of parents think the entire world's going to explode because their kid can't put the palms on the floor with the legs straight. So help the parent move through that one. So when we look at some of the risk factors for injury, in big picture with your young athletes, and this is from American Medical Society for Sports Medicine, prior injury is one of the biggest risk factors for future injury in the young athlete. We talked about the athlete in a growth spurt because of that bony weakness is definitely a point where they're at a higher risk for injury. They're also going to have high levels of growth, but their strength may not keep up with their height trajectory, right? So you're going to see these imbalances in strength based on the time that they are in their growth. There's some possible links to early specialization in sport and higher risk of injury. And also your athlete with a female athlete triad shows a much higher risk for fracture than athletes without that problem. Also, if we look at some of the other risk factors for injury in your young athlete, your nervous, skeletal system, and muscular system, they don't grow at a uniform rate, right? You've got this asynchrony of growth that happens as you go through the development process. So everything does not grow at a nice linear rate. Things grow at an uneven level. So that can expose the young individual to at higher risk for injury. Also, emotional maturity levels are a big component of risk for injury. Right? A lot of kids don't necessarily have the maturity that's necessary to understand they need to rest, they need to recover. So this is something that's going to vary from one athlete to another. And then again, with that asynchrony and growth in mind, you're changing limb length. It's going to cause changes in loading patterns. And the way I explain that a lot of times to parents, imagine your arm was an inch longer next week than it is this week, and you wanted to reach out and start the car. Right? It's going to be a little weird when you reach out if it's an inch difference than it was just a week ago. Now picture that in the framework of an athlete trying to develop some sport movement pattern. So these changes, because of growth, are going to cause these constant changes to their biomechanics and their movement pattern. So it's something to be aware of when we're working with these individuals. Big picture, things that we want to consider, and I have it as a rehab consideration, but it's something I think goes kind of across the board, whether you're working in the preventative aspect or the rehabilitation standpoint. The goals of the athlete, understand who they are, what they enjoy about sport. It may just be the social aspect, right? I want to get back to playing because I like doing that. I don't want to play in college. Understand that and respect and try to help that individual be able to do that. Understand whether they're in a supportive athletic environment or whether they're in a pressurized athletic environment. And just trying to, that's a lot of interpersonal skills. Getting to know the person you work with, getting to know the parents and the stakeholders will help you understand their environment. Try to consider the emotional maturity of the athlete. I've had some 8-year-olds that are much more mature than 16 and 18-year-olds that I've worked with. So understand their personality and their emotional maturity. Also their training maturity. I've had gymnasts literally that I've worked with that are 6 and 7 years old who've been involved in resistance training for 2 years. Right? They started when they were 5. They were exceptionally high-level gymnasts. I've had kids that are 17, 18, 19, 20 years old that are playing college athletics that have never been in the weight room before. So the training maturity of the 7-year-old was much higher than the older individual. Understand what they've been engaged in prior to developing the type of programming for that individual that you're considering. Understand the parental support. This is a significant component of a successful athlete in the long term, is having a good support unit around them. And understand their expectations for return to sport. An example, I had a kid who came in actually just a week and a half ago, and his ankle looked like something off of a horror movie. And his expectation was he was going to be able to go back to playing basketball at the end of the week. So we had to have a long discussion with him because it was his parents' expectation too. He couldn't fit his foot in his shoe at that point. So we had to kind of give him an idea of what was realistic based on healing, right? Because you can't beat biology. So he didn't have a realistic expectation of what to expect. So definitely start to understand where their expectations are when you're considering how to work with these individuals. So I'm going to burn through some of the apophyseal injuries that are pretty common to see in the young athlete. So Seaver's disease or calcaneal apophysitis is a pretty common one. This is heel pain in your young athlete. A lot of times they'll be diagnosed with an Achilles tendonitis. Kids between 8 to 15 years old probably don't have tendonitis. They probably have Seaver's disease. It's a pretty common injury. There isn't a lot of great evidence out there for what's the best thing to manage it. Most of the time, what most kids will get told is to rest. What most kids that are athletes that really like their sports don't want to do is rest. So a lot of times you have to figure out what's the best things to get this patient or individual back to what they were doing before, while still allowing them to participate in things that allow them that social engagement. This is a picture of a poorly managed patient with Seaver's disease. You can see kind of right back here. I'm not sure if you can see my little arrow circle on it back there, but that shouldn't look like that, right? That should not look like that. Some of our interventions that we can use for Seaver's disease, if you have this skill set, myofascial immobilization, so hands-on manual therapy work has been shown to be positive for managing pain. Rest from sport or modify their sport, right? Find ways where they can still engage in being active but not load as much. If you're skilled in manual therapy, joint mobilizations may be appropriate. Stretching may be appropriate. Don't always assume, though, that the patient's going to be tight. Right? It's not a fair assumption. You need to test to find out if it is or Also, strength training, cross training, taping has been shown in some studies to have some effect. And then orthotics. The literature on orthotics very mixed. So it's something that, again, I don't necessarily go to orthotics with somebody who's in a growth and development phase, but there is some literature, although the evidence is pretty limited, that they can have potentially a positive effect. Myofascial mobilization, I just want to throw a couple of pictures in. These are different areas and different techniques for myofascial mobilization. I'm not sure if you can see the look on my son's face up there. That's who my subject is, but his eyes are squinting. That's going to be really, really uncomfortable on the young athlete with this problem. So be aware of that and make them aware that, tell me if this is too much. Also, the picture on the top right is palpation of the soleus. And you can see on the bottom right that you come right across the medial aspect of the tibia and you can palpate the soleus. And that will usually be fairly tender as well. And your anterior tib, when you do this, a lot of times what you'll find is this is very tender and the patient will have referred pain going down to their foot. And they may tell you it feels like electricity going down to the top of my foot. Osgood Schlatter, this is going to be your most common apophyseal dysfunction, pretty common in boys 8 to 12 years old. You can see in this picture, there's your patella right up there. That's your kneecap. And if you just kind of follow straight down, those little chunks of white there, that's bone that's gotten pulled off. That, again, is not supposed to be like that. If you ever seen an adult with a knee that looks like that, you know that they had Osgood Schlatter when they were a kid. So they'll be impressed when you tell them, why, you must have played a lot of sports when you were younger. They'll say, how did you know that? And you say, well, I knew from looking at your knee. Right? That's what it looks like as an adult. That bony deformity stays like that, doesn't go away. Again, to manage Osgood Schlatter, very similar to what you're looking at to manage a Seaver's disease. Find the problems and then work on fixing the problems. So if it's tight, stretch it. If it's weak, strengthen it. If it doesn't have the mobility that it needs, mobilize it. I threw in a picture. Also, even though this is something at the knee, lots of research shows that addressing the hip when you have somebody with knee problems, very, very important to be able to get them an optimal outcome. So this picture is a Thomas test stretch is the name of this one. And it detects both quad tightness and tightness of the hip flexors as well. I threw this picture in just because I love it, because it's out of our library, but this will give you an idea of what's going on in your average jumping motion. So there's a lot more going on than just the knee, right? So don't just focus on quads when you have somebody with a knee problem. Appreciate lower leg, appreciate all the way up into the hip. And that's out of our library, out of the 3D anatomy. Very, very nice stuff. So. Little leaguer's elbow. So this is a medial humeral epicondyle apophysitis. So this is probably common in your throwers. It's going to be most common in the 9 to 10-year-olds. And this is something that you definitely see significant trends in your pro athletes, especially your pro pitchers. The most popular surgery right now in pro pitchers is the Tommy John surgery, right? And so this is usually the start of that later life dysfunction, is little leaguer's elbow. So one of the things that I look for when I'm considering whether it's a elbow strain, a sprain of the ligaments, or if it's an apophysitis, start to talk to the patient about how much they're playing. An example, I had a young athlete who was playing with me. He played third base, left field, pitched, and played catcher. So I didn't think it was any surprise that he had elbow pain at that point, because he played in travel teams in the summer, he played on his school team, and then he had played another team that he played on in the spring. And every position that he played required exceptionally high volume of throwing or exceptionally high intensity of throwing when he was involved in it. So my first suggestion to the parents, call up the coach and talk to them about first base, right? So start talking about positional changes. Teach the patient you can't throw that much all year round. You need to find a way to manage this better. This is going to be our most common medial overload injury seen, though, in your skeletally immature pitcher. So if you talk to somebody that does a lot of pitching and that's where their pain is, it's probably what you're talking about. Again, this is just some of the anatomy going on in that area. Your flexor pronator group is that picture on the left. Again, this is just another picture. And this is the idea. Even though you may have a problem at the elbow, consider all of the systems that we have to work on to help get that person back to functional. Right? Look at the whole individual, because that person at the early points, you may not be able to load up their elbow if they're early in the injury or if the injury is chronic, but you can get to areas that will help support and help them return to function. And again, lats, posterior shoulder, legs, trunk, core muscles, all important areas. Again, this is just another plain film image of a little leaguer's elbow. You can see that stress weakening at the bone epicondyle, and then you can see the healing that takes place after an appropriate amount of rest. Little leaguer shoulder, another common injury in the overhead athlete, especially your throwers. It's diagnosed more in baseball players, but I actually see it quite a bit in the tennis players I work with. Picture on the left, you can see that widened growth plate. And on the right, there's still that space there, but that's normal, right? That allows the bone to keep growing. So the difference is the width of that space. When it gets too wide, that's what develops that pain. Your little leaguer shoulder, you're going to see more often in your boys 13 to 16 years of age. And again, your overhead sports, pretty common: baseball, tennis, and volleyball. Tennis players, again, because I work with a lot of them, you may hear the report that they'll tell you, I can hit a forehand and a backhand, but I can't hit a serve. When I hit a serve, that's what really bothers. So that's one of my cues to begin considering little leaguer shoulder. And again, not very often do these kids have a rotator cuff tear. Old guys like me get rotator cuff tears. Young athlete gets apophysitis. This is a plain film image of a young man who I was working with. And again, this is why it's important. Don't necessarily get caught up in other people's report. Pay attention to the symptoms. So he reported pain that just was really kind of unrelenting. And I got a chance to see his imaging studies. And on his imaging study, the radiograph or the radiologist report is no abnormalities. But when you look close at the picture on the left, and I drew a little arrow there, you can see that big extra space that he had, right, on his right shoulder, which was, which was his throwing shoulder. And then you can see on the non-dominant side, he had that normal physis. So definitely with this young athlete, we definitely worked areas that weren't the shoulder, but I think that was more of his problem, even though it wasn't necessarily diagnosed. Ischial tuberosity apophysitis. This is going to be your young athlete who comes to you with the hamstring strain. Again, this is kind of an uncommon injury to have in a young athlete. The next picture, this is my son's butt. He had an ischial tuberosity apophyseal fracture. I told him he was going to be famous, so this is how he gets famous. You can see the big arrow, and in that arrow, there's a little thing there, and hopefully it comes through on your view of it. It looks like a big disc right there. That's not supposed to be like that. That's the apophysis. Basically, I wish there was something more glamorous that he did to do this, but he tripped over his own tennis racket at tennis practice. So I told him to tell somebody that it was in the overtime set and you were about to win the championship. Don't tell him you tripped over your own racket. But he gave himself an ischial tuberosity avulsion fracture from falling forward and trying to catch himself. That was about 12 weeks that it took him to be able to go back to playing tennis at a moderate level. So it was a pretty big injury. I threw this picture in because it shows common areas for apophyseal strains of the hip in your young athlete. And really what's really beneficial to know is to know your anatomy when you're working with young athletes. Pain in all of these different areas in a young athlete is going to be more commonly an apophyseal injury than it's going to be a muscle strain. ACL injuries, definitely one of the glamour injuries that's out there. So in your ACL injuries in the young athletes, again, based on your research, you've got high rates of this injury across all sports. It's most frequently a non-contact injury. So you don't have to have the big dramatic hit like you see a lot of times on TV. A lot of times people will say, I just stepped, planted, twisted, and I felt a pop. When we look at the anatomy of the ACL, we can kind of see that it blends with the meniscus. Overall, there's two different bundles of the ACL that tension at different points in both knee flexion and extension. And the configuration of those ligaments, they allow or they prevent translation of the tibia on the femur. So it's what keeps your knee from sliding apart when you step and try to stop yourself from running. This is just another picture from our library. It's going to show you what's going on at the ACL. So there's that tensioning of the ACL during the flexion. Then you see the PCL, or the posterior cruciate ligament, relaxes. And then you come back into extension, bang. This is a positive Lachman's test. So this is what I do when I'm trying to figure out, and what the orthopedic does when you're trying to figure out if there's an ACL tear. As you can guess, your knee should not move that much. That means that that ACL is not doing what it's supposed to do. So that's a full thickness tear of the ACL. You've got several different types of ACL repairs, and really the choice of the repair is based on the surgeon's skill with that approach, which we see you've got quad tendon, a peroneus longus autograft, allograft, they've got some synthetic grafts, patellar bone autografts. They also can harvest from the hamstring. That's just a nice picture of one being harvested from the hamstring. Probably shouldn't do this close to lunch. Sorry about that. And your patellar tendon is considered to be the gold standard for surgical choices with this injury. And your peroneus longus does have some advantages in that in the long term, they show less likelihood of an onset of arthritis. That is one of the problems that they do find when somebody has patellar tendon graft, is that they have some long-term potential for patellofemoral arthritis. So your most common issues that you're going to see with your ACL injured athlete are loss of full extension, knee pain, swelling, and strength deficits of the quad muscle. The other problem that you have with a common injury with the ACL rehab is the patient doesn't do their exercises. Right? So even though they're an athlete, a lot of times they don't do the exercise that you ask them. Keys to early success: manage the swelling, get full extension, get the quads to fire, restore patellar mobility, and teach them how to walk again. Walking is actually one of the more difficult things that people have to do after a lower extremity injury. And some early interventions, and again, you'll be able to see this if you want to go back and look, but I'm a big fan of the University of Delaware. They have some great protocols for post-surgical management, and they have a very nice ACL protocol that's available. Just to give you an idea how much force goes into the ACL, Escamilla did a really nice study in 2012 that just looked at how much force goes into the anterior cruciate ligaments during different activities. And they used newtons of force, and 1 Newton is equal to about 0.22 pounds, not very much. Standard squat, no load onto the ACL. So squat's very, very safe exercise to do with an ACL patient. Leg extension, 248 newtons. So that's quite a bit of force. Overall, though, not a huge amount if we just did the volume and the numbers on it, especially if we compare it to walking. Toe off on the contralateral lower extremity creates 300 newtons of force on the ACL. So if somebody's walking around the earth with an ACL, they're putting more force on it than you can put with most of the exercises that you pick. All right, so that's usually one of the things that you consider. Just your day-to-day functional activities do create a lot of load on the ACL. This is one of my favorite pictures because I did live in Virginia for quite a while, and it was when Robert Griffith was kind of a sensation. These are his pictures in combines. And if you can see his knees in his jumping, that knee valgus is what that's called. That's mnemonic for somebody who's about to blow out their ACL. Right? That is a really, really poor movement pattern, and I still have trouble figuring out who didn't pick that up in his draft stock. And you can see it on the Subway ad too. It's that same knee valgus as he's going into the jumping motion. So if you see a young athlete that does a squat like that, if they don't have an ACL injury, it's coming. Retrain their movement patterns. This is also a picture of somebody going through 1A is a pretty good squat pattern. B, C, and D, not so good. And you can see trunk lean, hip shift, knee valgus. So these are all some poor movement patterns that you may identify in the young athlete who may have potential for injuring the ACL later on. Spondylolysis, this is a fracture in the spine that's commonly seen in young athletes. Again, if you got a young athlete that's had chronic back pain, that's something you want to be really, really aware of. Usually, young people don't have chronic pain. It's not something that's common. In a spondylolysis, you can have a defect, an anatomical defect of the pars interarticularis. But this fracture occurs a lot of times in sports that involve extension and rotation, like gymnastics, or loaded axial loading sports, like in football, an offensive lineman, common one. In the tennis serve, also in the volleyball, spiking motion is a rotation and extension. You've got some different categories for spondylolysis. The big picture thing is that if this is not identified early, it can progress to a full fracture with non-union. And what that means is that when that individual is 25, 30, 35, and 40, much higher likelihood of the early onset of spinal stenosis due to that fracture and poor stability at that level. This is it's a big picture one for us to manage and be aware of in the young athlete to be preventative for long-term back problems. This is just another picture. Fortunately, this isn't any of my children, right? This made me happy. This was somebody I was working with, though. They had a full fracture with a shift, and you can see how the spine does not line up like it's supposed to. It's supposed to have a nice, even curvature. So they have an anterololesthesis, which means an anterior slippage of L4 on L5, plus that fracture right where that big blue arrow is. So a young athlete with persistent low back pain definitely is somebody that you want to refer to the doctor for plain film imaging. If they have not had it yet, really, really important, get them to the doctor. It's unusual for a young individual to have chronic low back pain. So send them to the right person. This is just one more picture of a spondy. Overall management strategies when that individual is cleared include dealing with the problem. So poor core strength, hamstring flexibility, hip flexibility, and working on conditioning while still letting their body heal. There's some discussion when the spondylolysis becomes chronic about putting them in a thoracolumbar orthosis, which looks like a big turtle shell. I've had several patients that have been recommended to do this. The problem is getting somebody between 14 and 16 years of age to wear a turtle shell all day long for 3 months. There's a low level of adherence to those. So a lot of times you don't see them recommended as much. Just a couple of exercises. Again, my son, after his fracture, this was something that we worked on, but it's also a good low back exercise. When we look at concussion, this is going to be our last one, some definitions of a concussion and some of the injury trends with this. So you got about 136,000 sport-related concussions that occur every year. Post-concussion syndrome develops in anywhere between 1.5 to 15% of these individuals who sustain a concussion. The most frequent sports this is seen in include football, and females in soccer are the highest rates of concussions. Most concussions, you don't see that loss of consciousness or observable neurologic signs. The difference between a concussion and post-concussion syndrome is that in a concussion, most symptoms resolve in 2 to 7 days. Post-concussion syndrome is when those symptoms last out past that 7-day mark. And this is a real problem area in management because a lot of times what you see in these individuals, poor ability to concentrate, it affects them both academically as well as athletically. So a long-term concussion can be something that really significantly affects that person's ability to function at their normal level. Overall, the pathophysiology of a concussion, it can be from a direct impact, or it can be also from a rotational or acceleration-deceleration force. And again, I spoke with Dr. McLeod, and she's one of the PhDs and a professor at A.T. Still University and one of the leaders in concussion research. Does just incredible work, and a lot of great research is out there from her and the groups that she's been involved with. But the two biggest area of changes that she's identified in concussive management include the sideline assessment and management, and then movement away from absolute rest in the periods after concussion. The best practice guidelines right now for management of the concussion, there aren't any really. What she had identified as being one of the big problems. This is such a new area of research and something that's really in its early stages of understanding, that these best practice guidelines are in an evolution point. And you've got some pretty good tests overall, but one of the things that she did identify is there's no single test that's the gold standard. You want to have a battery of tests to best identify these individuals and rely on a complete exam, not a single test. And these, again, are some of the screening tools. This is your Glasgow Coma Scale, if anybody wants to go back and look at that later. Our big picture that we want to look at is our overall takeaway from all this is to be part of the solution. So our problems are increasing injury rates, single sport participation, and an increased focus on performance, not on enjoyment. The result of this is increased dropout rates from sports, decreased exercise, burnout, long-term musculoskeletal dysfunction, and an increased burden on your healthcare system and an effect on population health. Solutions that we can consider: education of parents, coaches, and players on the importance of prevention strategies, factors that increase injury risk and how to best avoid those factors, and then understanding how long does it take somebody to heal up, right? Because you can't beat biology. Don't be a dinosaur. Don't go no pain, no gain. Don't go through and use strategies that punishment to get better, right? That's a dinosaur thought process. We want to go past that, be part of the solution and recognizing the value of multi-sport participation, encouraging active warm-ups and resistance training for these individuals has been shown time and time again to decrease injury rate, and provide a reality check to both the athlete and the parents. Your odds of becoming a professional athlete, they're about equivalent of becoming a brain surgeon if you look at the statistics. So help people realize that just because your child is a good performer at 12 years old does not mean they're the next Tiger Woods, right? They don't have to be. Help them enjoy what they're doing, help them be healthy, and that's the real goal. Thank you to everybody. I think I ran just a little bit over, so I appreciate everybody signing on today and listening to me yammer on. So.
Okay, thank you, Paul. If anybody has any questions for Paul, please unmute yourself and ask. You can unmute yourself by clicking on the microphone lower left corner of your screen. If you're having issues unmuting yourself, then please let me know in the chat.
Hello, Dr. Frizelle. Can you hear me?
Yes, sir.
Hi, this is Chris Gizzi. I'm a strength and conditioning coach right now.
How you doing?
Good, man. Thank you so much for the talk. That was great.
Yeah. Oh, great. Thank you.
Hey, I had one question for you. You kind of, right from the beginning, you talked about club sports.
Mm-hmm.
The club sport athlete, obviously playing on multiple teams, maybe even in the same season.
Yeah.
Have you had any relationships with club sport directors or coaches? And if you could you just share a little bit about that?
Yeah, so when I try to talk to these people, one of the first things I usually get is a lot of the club sport, because a lot of times these individuals, this is a job for them. They get paid to do it, right? And so a lot of times they think my goal is to get the athlete to not play and to stop playing. And one of the things I try to talk to them about is what I would like to do as both a rehab specialist and as a strength and conditioning person, is that it's not that I necessarily want them to stop playing, it's that I want to help them get interventions that will help them play at the level that they want to play at. And a lot of times this might involve the idea of teaching them about the importance of recovery, nutrition, resistance training, appropriate warm-ups. So my approach with the coaches is to work on the idea that, I don't want your athletes. I want athletes to continue playing, right? I don't want them to force them to play, but if that's what they want to do, I want to help them get the most out of it, and I want to increase their availability to training. Here's the tools that the evidence shows that can do that. Teach them, here's dynamic group warm-ups. So if you're working with a team, implementing like that, I don't know if you've heard, there's a FIFA plus 11 dynamic warm-up that they've shown in Europe that decreases ACL injury rates. So another example, gymnastics school. I went over there and worked with a coach because she had come to my facility and said, I've got about 8 of my gymnasts that have knee pain. What's going on? So I went over and tested all of their hip strength, and they could all barely hold their leg up against gravity. But these young ladies can do flips and incredibly strong legs, but incredibly weak hips for the strength of their legs. So it was about showing them, here's where the deficits might be. Why don't you incorporate this into what you're doing with your athletes, because it may help manage them better. It may help them not have these problems. So that's kind of where I've had some luck with it. It's definitely challenging, though. A lot of people think you want them to stop doing it, or that you want to take their athletes away from them. So,
yeah, I think you hit it on the head. The interpersonal skills that are required to manage that situation, because it is a management situation, whether you or a professional that is engaged with the organization. There is a focus on performance, which, depending on the age, may or may not be something that's sought by the athlete. It's something that I know in a lot of the worst cases is there's a conflict of interest. What has gone from 2 seasons a year now becomes 3, becomes 4, and if you're not playing on all the teams, you're not playing on any of the teams. Again, just wanting to share that, put that back, because I believe in the worst case as well as the best case scenarios. Finding the ways that we can impact in our own lives as professionals and as parents is definitely something I'm interested in.
Absolutely.
Thank you.
Absolutely.
Do we have any other questions?
Hey, Paul, it's Tracy. I just wanted to say great job.
Oh, thank you, Tracy. I appreciate it very much. Thank you for watching.
Of course. Yeah. Thanks for all you do for the program and the college.
Absolutely. Absolutely.
Hi, this is SD Shanti. I have a question for you, please.
Sure.
Thank you so much for a very interesting presentation. I have a couple of concerns about where society and cultural norms are going based on what you mentioned. One was your comment about the reduction in free play and all the benefits of that. And is that something that you think that we in public health could work with you on to promote? And the second thing is this whole parent pressure thing, what you were talking about, the investment and so on. It seems like this is one more thing chipping away at childhood. And so related to the second part, what are your thoughts on how we might change the culture around that? So I guess it's a 2-part question.
I mean, I think that's from a big picture, I guess I can answer you from both a big picture population health standpoint and then a parent standpoint. So we've got 2 parents who work in one house, which a lot of parents have and a lot of households have. So a lot of times there's a convenience in going to something that's scheduled, Also, you're talking about a society that's more spread out. You don't have the neighborhoods. And this is something that, you see it, I think it's kind of from a big picture population health standpoint, but also a reflection on society. Sometimes people think you're crazy for letting your kid go out and play without monitoring everything that they're doing. you're going to go out and let your kid play out in the street, in the neighborhood, unsupervised with nobody there. And, it's kind of a function of what you get to see on the news every day, the fear that's involved. And so I don't know that you necessarily can escape that at this point. I wish, I know from a parent, there's times where, I'm sitting there at the window watching my kids and they're playing right in the side yard with the other kids from the neighborhood. I'm thinking to myself, why do I got to watch? I live in a gated community. I don't have to. It's not a bad area, but I think there can be a guilt factor to it. Society is definitely much more spread out. Society is much more focused on work. It may be something also that may be a function of the United States. I don't know that these trends are the same in other countries. So you may see it as being a geographic issue. So it's something I think that definitely from a population health standpoint, it'd be interesting to see the research if it correlated in different communities where the communities are closer or different countries had the same type of trends. So, but I do think you're seeing just kind of that combination of both the cultural and societal norms for acceptance of what's acceptable parenting, and then how you can get your kids to an area where they can participate in something that is safe and that they're going to get their exercise and they're going to be able to do those things. So a really complex question. I wish I had a better answer.
This seems to be related also to the decrease in recess time. So I'm a psychologist, and I'm wondering, what does this mean for child development when we have fewer opportunities for spontaneous, unstructured play, less recess, again, which is unstructured? I find that kind of concerning.
I think you could say the same thing about art class and music class and all of these decreased, activities that are looked at as non-essential in school because they don't contribute to a test score, all contribute to the development of the individual. So I think that's a problem that's, you look at it really from that broader perspective, not just the phys ed, but you see it, art class is less, music class is less, all the way across the board. And that all contributes to affecting. And I think you look at budgets, the realistic component of what are people in the society willing to pay for? What do they see the reward of it being? So it's really complex because I think you start taking into effect economic factors, socioeconomic factors, cultural norms. That's a really probably above my pay grade several levels to even get a halfway intelligent answer out of it. So,
well, thank you.
Yeah.
Thank you for a really wonderful presentation and opening our eyes to these issues.
Thank you. I appreciate the questions.
Do we have any other questions?
Dr. Frizelle, how do we stay in touch, follow you, anything social media? What's your platform?
You could go into the human or the kinesiology degree program. I teach several courses there. I'm not really very present on social media. So, I have a Twitter, but I just repost things from the radiology sites. So you'll see a lot of fractures on my Twitter posts. That's about it. So yeah, I don't do too much social media wise. I do teach some courses. I'm doing continuing ed courses for PTs and OTs. I've got a couple set up for this year, but as of right now, my primary involvement is outpatient orthopedics and then ET still teaching in the program there. So give me a thought though. Maybe I got to get a Twitter account and get more active.
Hey, it's tough. It's a burden. But sometimes a welcome burden because it just connects. But I tell you what, I'm in the Doctor of Health Science program right now at AT still, so I'll track your email down.
Fantastic. Thank you so much for asking.
Yes, thank you, sir.
Yep.
Okay, do we have any other questions? Well, sounds like everyone's it's pretty silent at this point, so I appreciate the very informative talk, Paul.
Thank you very much for having me. It's a lot of fun.
Oh, okay.
Yeah.
Thank you, everyone. I appreciate it. Have a good one.
Take care. Bye-bye.
Bye-bye.
Yeah, I'm